pleasure having you here, and thank you for spending your Saturday morning with us. It was an honor to have you. Our next speaker, Dr. Winkfield. Dr. Winkfield is a radiation oncologist at Vanderbilt. She has several administrative roles, including our own U54. She is one of the leaders on our cancer outreach. Currently, will have more administrative roles, I guess. And also, she is one of the executive director. She is the executive director of Meharry-Vanderbilt Alliance. Dr. Winkfield, thank you for joining us, and please take it away.
Awesome. Thank you so much. Can everybody hear me okay? I just want to make sure, and then I'm going to try to get my slides up. First of all, I want to thank Dr. McDonald for that amazing overview, because I think it sets the tone for a lot of the things that those of us who are on this call know quite well about the issues related to access to care and disparities. And I'm going to just, really thread my comments through the information that she's already presented, but to really put the spin on it in terms of what do we want to do with this partnership. I am so thrilled to hear about the score. That's amazing. So congratulations to all of the leaders who have been involved with that. But I do think it's important to think about implementation. Where do we go from here? And how do we actually utilize the partnership to bridge some of those gaps that Dr. McDonald so eloquently described? And I have got to give a shout out to one of my mentors, Dr. Linda Clayton, who I've known since my days at Harvard. And I'm so grateful that she's on this call today, because as you know, she and her husband, her late husband, Dr. Michael Bird, may he rest in peace, wrote An American Health Dilemma, which for me was really eye-opening. We've spent decades describing the inequities that exist, the tragic history in this country, specifically related to Blacks, and yet there's still gaps that exist. I believe this partnership has this golden opportunity to actually show how we can leverage the expertise at multiple institutions to really close those gaps. And so I'm grateful to be here. I'm grateful that I have an opportunity to be the executive director. I'm grateful to the search committee. I'm very, very thankful to Dr. Peyton Pohl and Dr. Eric Shinhara at the Cancer Center for really understanding the value of community engagement, knowing that that's my area of expertise. Yes, I'm a radiation oncologist. Yes, I believe that cancer care is important, but we also need to get people into the doors of the healthcare system. And we also have to understand the context that people are in. So this is why I want to start with a definition. I think oftentimes people think of health disparities as just as the differences in terms of incidence, prevalence, mortality, burden of diseases that exist between different populations. But I want to stress this one phrase: and other adverse health conditions. And COVID has certainly highlighted what some of those adverse health conditions are. Living conditions, right? You think about the individuals who had increased risk related to COVID, those who may be living in densely populated areas or where there's racial housing segregation, perhaps lack of transportation, right? Nashville, big city, not great public transportation, but what happens if that's your only mode of getting to and from, whether it be job or access to health? Work circumstances, people being claimed or called essential workers, but not being allowed to have the same protections as other folks. Maybe these are the folks who are the environmental services, essential workers, but not given the same benefits as other individuals who can work from home. They have to come in to do their job, right? Many times they don't have sick leaves, or they're uninsured or underinsured. These are all of those conditions that we saw have and result in increased risk related to COVID-19. But those of us who are clinicians and oncologists and those who work in the oncology workspace see these same conditions played out in oncology care. When you can't get to and from a location, when you need chemotherapy, when you need radiation therapy on a daily basis, and transportation is your number one burden or barrier, that's a problem. But we know that across the country, transportation is the number one barrier to cancer care. We also know that work circumstances, if individuals are paid by the hour and not salaried, that's a problem when they need to potentially take public transportation to get somewhere, or even if they don't, even if they have to come in and park. Sometimes it could be half a day for an appointment. And we certainly know the issues related to insurance. Are cancer centers accepting all modalities of payment? And if not, why not? And if not, who are they excluding? These are all the issues that we see front and center, not only with COVID, but with cancer care. And so when we look at the COVID-19 death rates, I'm again grateful to Dr. McDonald. She brought it home. She shared what was happening in Nashville, in the region. And I think that that's important for us to keep in mind our catchment. Who are we serving through this partnership? But we also can learn those lessons, what's happening nationwide when we look at Indigenous populations having the highest death rates, followed by Blacks. And I think these numbers have shifted. This is data from January. And again, we're seeing evolving data. Some of that evolution is because people are starting to now report race and ethnicity. As you recall, that wasn't originally the case. But this is a problem. If there are certain populations that are disproportionately impacted, and it's not just the death rate, we have to look at other issues related to COVID-19. Yes, the infection rate, but hospitalizations. Again, seeing Black and brown people in the United States having the highest risk for comorbid conditions, but also some of the risk related to COVID. And you see the CDC, this was just back in April, I believe, had recommended still wearing masks and staying 6 feet apart. But with some of those recommendations shifting, what's going to happen to those populations that are at greatest risk? Here we know we have so many cases in the United States. We are unfortunately leading the world in terms of number of new cases and also deaths. But we also know that we are doing a great job rolling out the vaccine, but it's been heard, not everyone has the same access. Great that there are vaccines that have been distributed, but actually in the United States, only 30% of individuals have had a full complement of vaccines. We're getting there. And the good news is Dr. Fauci just recently put out a statement stating that if we can get 70% of people in the country to get at least one dose of the vaccine, then we're going to be headed in a better direction. Maybe won't have the same bump that some of us are fearing with the shift in terms of the recommendations related to mask wearing. I worry that, again, those barriers, those systemic barriers that we talk about are going to disproportionately impact the people who really need the support most. And so this is a slide deck. Many of you know I work with the National Institutes of Health, their SEAL teams. I lead their inclusive participation work group, which is really focused around community engagement and how do you help and get to the community and work with the community to help reduce some of these disparities. And this is a slide deck that I received from that group, where showing that, again, Black and brown individuals are not getting vaccinated at the same rates. And so if you look at the gray bar underneath shows the population, and the colored bar on top says how many of those individuals have actually gotten the vaccine. So we've got some work to do. And again, as I'm worried about, some of you might be, that some of the newer recommendations may disproportionately impact communities of color, just the same way that originally when the CDC did want to say public mask, public wearing of face masks in public places, including public transportation, there was a refusal or they were blocked from actually providing that recommendation. And we saw some of the uptick related to not allowing individuals to be protected. So again, these increased COVID-19 risks, very similar to what we're seeing in cancer care. And I must point out the chronic conditions and comorbidities. I think this is something that, again, Dr. McDonald certainly broached. When you look at some of the leading comorbidities that were affiliated and associated with deaths, starting in New York, I'm picking New York because that's where they had this is where all this major thing started. We got a lot of data out of that incidence. Hypertension, diabetes, hyperlipidemia. Those three things were associated with death from COVID-19. And here again, if we look at the leading health disparities, and I'm going to pick Blacks because here in our region, Blacks are the greatest minority group, if you will, in our region. Obesity, cardiovascular disease, diabetes, all of those things are disproportionately impacting Black individuals here in our region. And certainly we know if we look across the country, if we look at American Indians, and certainly obesity, upswing in Hispanic populations, these things are disproportionately impacting communities of color and rural populations. Mental health, huge issue, but so is cancer. And again, you all know these numbers and probably have already read the AACR Cancer Disparities Progress Report that launched last September. Yes, the numbers are better. Yes, we're seeing a decline in terms of the gaps between Blacks and whites in terms of cancer death rates. But the fact that Blacks are still dying and that there's still a gap, that when you look at those trend lines, yes, everything is getting better. We are doing better in terms of curing cancers and allowing individuals who have cancers to live longer with cancer. It's becoming more of a chronic condition, if you will, but not every population is benefiting in the same manner because of lack of access to clinical trials, lack of access to care, and lack of access along the cancer continuum. So I really think one of the things that I would love to see this partnership really think about is how do we actually change some of the systemic inequities that might be preventing some of our population, some of the people we care about, our communities, from getting the appropriate cancer care that they need. This was a paper that my colleagues and I wrote related to lessons from COVID-19. How do we address health equity in cancer care? And we published this in the Red Journal. It was specific to radiation oncologists. I mean, that was the audience we were speaking to. But frankly, a lot of the tenets that we talked about are broadly applicable to oncology. We need more research and advocacy for health equity. Yes, in the form of clinical trials, but again, not just the descriptive stuff, not just the, okay, we're gonna do a longitudinal group and we're gonna follow them along and see how things change or don't change. I mean, those are fine. And you know what? There are researchers who get billions of dollars or millions of dollars of funding to kind of do these large database analyses that just describe something. What about implementing change? What about thinking about clinical trials that actually are looking at the institutional level? How can we actually change practice? How can we change what happens at our institutions to really make it so that we are making a change in everyday patients' lives? You know, the policy implications are huge. And many of you know I'm a policy wonk. I work with ASCO's Government Relations Committee. Pre-COVID, I was down on the Hill. You know, I'm so excited that Nashville, I will be able to hopefully be face-to-face with legislators, right? But we also need to think about policy implications for departments, for institutions. Again, do we accept all insurance? And if not, why not? And if not, who are we excluding? If we're going to want people, particularly people of color, to engage in clinical trials, we have to make it easy. We have to make sure all doors are open. And that's critical. Dr. McDonald also talked about workforce. And again, this is an area I'm very passionate about. And yes, I would love to see more diversity in the oncology workforce. Some of my papers have outlined the fact that only 3% of oncologists here in the United States are Black. Only 3%, and only 4% are Hispanic. It takes a long time to grow up an oncologist. So let's think about the other members of the care team. What about our nursing staff? What about the people who are welcoming individuals into the cancer centers? What about the individuals who are on our research teams? Are they diverse? Can we do better? These are the things that hopefully, again, our partnership will think about. Are there ways that we can do collaborative recruitment to make sure we're bringing the best individuals into the partnership to help shape the work that we do? And I know we are doing a phenomenal job of doing collaborations with communities and community engaged researchers. It is fabulous work that the partnership is doing, and I'm looking forward to really working with you all to really augment all of the excellent work that's already being done. This is a paper that my colleagues and I published in January of this year, where we outlined and developed the actionable framework to address cancer care disparities in medically underserved populations. And this is actually the culmination of several years of work. We actually had a roundtable that we pulled together in 2018 with experts around the country who were doing boots on the ground work, not necessarily those who published the most, because we know that there are people who can write, but can you implement? And so we actually went and looked for people who had implementable programs that have shown benefit. And we actually took some time to say, well, who are the stakeholders who are responsible, who potentially could be responsible for implementing the framework? And it's really important to know, again, it's not single institutions. They are important. Healthcare leaders are important, but so are advocacy groups, so are legislators, so are community outreach leaders. So it's important to know that this has to be broad work. It has to be community engaged. Again, we are doing that in spades with the partnership, and I'm so thrilled. Now, can we make sure that our institutions are helping us with our mission? That's important. We have to have policy change at every single level, and they are our partners and stakeholders as well. And I'm going to say the framework that we put together is not just applicable to race and ethnicity. It does take into consideration other vulnerable populations, including rural populations, differently abled, LGBTQ plus communities. And so this framework, while we talk about it from a cancer lens, certainly is broadly applicable to other disease states as well. And that's an important thing to keep in mind, particularly when we go to our community and cancer is not number one. That might not be the number one thing on their mind. So this is an important framework. And the framework really does look at the issues along the entire cancer control continuum. Prevention is key. And I understand, like, we don't, as oncologists, get paid for prevention, which is a whole other issue, but it's important. Right? There are two greatest modifiable risk factors, tobacco use and obesity. Those are the two greatest modifiable risk factors for cancer. And in our region, two of the greatest problems. So we are already working on that. I know we had a tobacco cessation programming that came through. We need to start looking at physical activity and pulling in our faith-based organizations to help assist with some of that. I know there's some discussions around that. We have some great researchers who are doing that work, but prevention, really key. But we also need to make sure people have the capacity to get into screening. Again, grateful to Dr. McDonald. She shared some of the thoughts about screening and getting people back up. COVID has slowed down cancer screening, as you know, and there's some concern that there's going to be some stage migration. And certainly the hope is that with newer modalities of treatment, that we will still be able to get people into either cure or remissions. But there's a fear again that not every population is going to benefit. So we need to be thoughtful about how we actually address cancer disparities and cancer equity along the entire cancer control continuum. And again, the things that we talked about in this framework really do go through the gaps in care that can happen as a person passes along each phase of the cancer control continuum. But the number one thing to keep in mind is community engagement. That is an important component of the work that we do. And again, I'm so grateful that this partnership has really been leading the forefront in that region. So the importance of this, and I'm about to wrap up, is the fact that these social determinants of health happen outside of the context, oftentimes, of the healthcare system. And this is why we've got to engage the community. This is why we need to understand how employment or the lack thereof, or the shifts and changes that have happened with COVID have impacted people's ability to actually get healthcare and to get cancer care. We know that cancer care is the number one cause of medical bankruptcy in the United States. Something has to change. What are the things that we can do as part of this partnership to help shift some of the burden from patients and families and really help to lift everyone? Housing. We understand that, yes, segregation still exists, maybe in the form of redlining, but I also talk about medical redlining, because if there are populations who cannot walk through the door of your cancer center for whatever reason, maybe they have the wrong insurance card, maybe they're afraid, that's medical redlining. And what are the things that we can do as a partnership to help alleviate some of that? And I must say, one of the things that I talk about is the fact that community engagement is actually one of the social determinants of health. So it's a way that we can leverage our expertise to really help shift the dynamics of the social determinants so that we can make an impact in terms of outcomes. So I want to thank you all for your time. I'm so grateful to be a part of this partnership. I'm so grateful for the invitation to speak today. And I am so excited for the rest of today. My good friend, Dr. Rob Wynn, is going to be the keynote. I'm excited about that. And I'm going to be trying to live tweet this during the discussion. So I just want to thank you so much. And if you have any questions, I'm available.
Thank you so much, Dr. Winkfield. In view of time, we have one question, and there is one question in the chat box. I'm going to read it to you, and we'll entertain one more question. Okay, so the question in the chat box is, in your experience, what methods, I assume social intervention methods, have proved most successful in increasing community engagement?
Yeah, so, I think the biggest thing is being present without wanting something. And the individuals that I've seen, the programs that I've seen that have been the most successful at community engagement are those that spent time in the community just building rapport without asking somebody to do a research study, without asking for them to come in and we need your help. It's literally just about being present and asking people what they want and what they need. How could we help support that? So if you look at there was a great paper by Dr. Jeannie Rignanti that looked at clinical trials and clinical trial engagement, and the centers, the cancer centers around, these are all NCI designated cancer centers, but have had the best impact in terms of enrolling moderated populations. They've had a boots on the ground presence, just being there because it's the right thing to do, whether it be kind of going to health fairs or kind of helping out races, whatever it is, giving talks in the community, not asking for anything. I think that's a strategy that really can be employed in a very good manner, but it does take time. And so I oftentimes say you can't get an NIH grant to build relationships, but that's where institutional investment comes in.
Great answer. Just be there. Okay, one more question.